Hello and welcome to Season 2, Episode 75 of the Physician Assistant Exam Review Podcast. My name is Brian Wallace, and this week we're going to be continuing hematology with anemias, specifically microcytic anemias. All right, welcome aboard. My name is Brian Wallace. I'm the host and creator here at physicianassistantexamreview.com. That's the website, and this is the podcast. I'm so excited to have you here with us as we move through hematology and we start to explain some of the ways to think about this material and to see what we're going to talk about at the end is a little bit of the bigger picture. We talked about that in the last episode, but we're going to talk about it a little bit more and expand on that idea a little bit more this week because it's an idea that really makes a big difference in how you study and how you see your tests, how you prepare for your exams. Very specifically in the May issue of the Physician Assistant Exam Scholars newsletter, which goes out on May 1st, I'm covering some very specific ideas on how to prepare, how to study. But in order to use the techniques that I put into that newsletter, you have to really be able to see the big picture. You have to be able to see the whole thing. And as we move through anemias today, you'll start to see how that unfolds and how that works. So anyway, what I want to do today is start with anemia. And let's just start with a couple of priming questions. So what is the test for measuring red blood cell size? What is the test for measuring red blood cell size? We covered that last episode. Define microcytic anemia. Define microcytic anemia. Give two symptoms of anemia. Two symptoms of anemia. Give two causes of anemia. Give two causes of anemia. What two types of anemia are associated with Heinz bodies? Heinz bodies, what should those make you think of? All right, let's break in and talk a little bit about anemia. All right, anemia means that you have a low red blood cell or hemoglobin count, right? So you're not carrying enough oxygen around in the body to get to the cells that need it. So you're in a situation where you have either malfunctioning red blood cells, you have maybe poorly formed hemoglobin within the red blood cells, or some kind of problem with oxygen transport due to either red blood cell production, red blood cell shape and size, or the hemoglobin inside of those red blood cells that it's not functioning correctly. There's some kind of problem there. This can be caused for a number of reasons that we're going to get through. Today we're going to talk specifically about microcytic anemias, which means that the cells are very small. The red blood cells are very small, microcytic, right? That's defined as less than, on an MCV, it's less than 80. And we'll get into macrocytic anemias in the next episode, I believe. I'm not sure exactly how it's staggered out. The point is, when you look at anemia, what we're trying to do is decide what's the cause, right? Because I'd have patients come in when I work in the office, and they would say things like, they'd come in with some pain in their, let's just say they had pain in their ankle, right? And you look at it and you're like, this could be one of a couple of things. I'm not really sure. We should probably get an MRI and make some decisions. And they'll say, well, what are we going to treat? What are we going to do? What should I go for therapy? And I'd say, no, I don't know what the problem is, so we're not going to treat it yet. There's nothing to treat because I don't know what the problem is. And they'd say, well, what are we going to do? And I'd say, nothing. We're going to go get the MRI and get our answer. It works very similarly with anemia. Anemia means you have a low red blood cell count, right? Or a low hemoglobin count. But there are a number of things that can cause that, and how you treat it all depends on what's causing it and what the problem actually is. So yes, I guess you could transfuse people for anemia. That'd be a place to kind of like using a bigger hammer right out of the gate if you need to, of course, but probably not the place to, it's not the subtle way, right? It's not. So our job here is to figure out what types of anemia we're dealing with and then treating those types. And quite honestly, that's going to be if you're in the clinic, but it's also going to be on your tests, right? So I like to teach things with the test in mind. How would I handle it? How would I write test questions about it? What would I do? What am I looking for that I'm going to write test questions on? But also those are things that are how people are going to present in the office, and the problems and the puzzles you're going to have to solve in the office setting as well. So it works both ways. Sometimes I get some pushback for teaching to the test, and I do teach directly to the test because that's my number one goal, is to get you to pass PA school and then to pass the PANCE or the PANRE. But I also want you to be a decent clinician, and a lot of this stuff goes hand in hand. It's not necessarily separate. It can be, but and I'll touch on those when they happen, but it's not necessarily separate. And our main goal as we work our way through anemias is to understand the big picture of what anemia is and what we're trying to accomplish. And what we're trying to accomplish is figuring out the reason for that low red blood cell count, figuring out the reason for that low hemoglobin count. Those are our goals, right? It isn't to use that big hammer. It's to identify the problem and then fix the problem with the right solution. All right, so let's talk about a couple of definitions that I should have hit on last episode and I did not. But as we move through this, we'll clear them up. Target cells are the term we're going to use today. And I like to do some of these up front so that I don't keep repeating them throughout the context here. I like to separate them here in the beginning so they make sense once we get there and I don't have to keep repeating the definitions. So target cells. These are red blood cells, which appear pale in the middle and then red around the rim. So they look like a bullseye. It just has to do with their shape, but it makes them a little less functional because their surface area is messed up compared to their size. It's really what winds up happening. So you get red blood cells that appear pale in the middle and then red on the outside. So these are target cells. And they're not really great functioning red blood cells. These can be seen in obstructive liver disease, thalassemias, hemoglobin C and D, sickle cell disease, iron deficiency anemia, and post-splenectomy. So these aren't real helpful to determine which type of thing is going on. They're a little bit of a clue, but they're not definitive. But anyway, I want you just to be aware of those as we move on. Hypochromic means the cells appear a little pale under microscope due to a lack of hemoglobin or a low hemoglobin within a red blood cell. Hypochromic. Red blood cell distribution width, or RDW. And this is a measurement of the size of the red blood cells and how different they are from each other. So normally, if you think about it, in circulation, most red blood cells should be about the same size, right? Plus or minus a little within reason, but they shouldn't be one teeny tiny, one really big, some in the middle, a couple really small. That just shouldn't be how they are produced and circulating. So that is what our DW is testing for. I'm slowing down a little and stammering a little because the next two terms are ones I struggle with, and my word finding is a little rough, even when in my pronunciation is a little rough. Is anacytosis, which is when red blood cells vary in size. I'm not even going to repeat that one, but that's when red blood cells vary in size. You can find it in the notes if you want to go over to the website and check that out. So that's an increased RDW. Anacytosis. Anacytosis, we're going to let it go there. And then poikilocytosis is when the red blood cells have a different or abnormal shapes. So sickle cell would be poikilocytosis. I think I nailed it. All right, so microcytic anemias. We're going to go through a couple different types. They are going to be iron deficiency anemia, thalassemias, sideroblastic anemia, and anemia of chronic disease. Those are going to be our microcytic anemias. Now, don't hold me to any of these. Some of these may have a little variability in them. Some other things may cross over in here. I know students in general and people in general struggle with the idea that everything has to be black and white. And almost nothing in medicine is black and white. There's a lot of overlap. Most things are on a spectrum from one end to the other. Not that they have to be at one end or the other, but that some things just cross back and forth. So you may see sometimes something's a little macrocytic in the beginning and then becomes microcytic later on. But in general, if we classify these into these more black and white categories, it's easier for you to remember, especially as you're learning them. Then later down the road, you can learn the nuance of when those categories aren't so strict and where that spectrum fits in. I hope that makes sense. But it's helpful to really categorize these as concrete categories like microcytic and macrocytic, hypochromic, those things right up front. And then later on, as you fill in the details, you can start to let some of those cross over a little bit where they do and start to understand how that works. So please don't take me at exactly my word on all these. This is for test taking, for learning purposes. We're going to keep things really hard and concrete. So these are going to be with an MCV below 80, a mean corpuscular volume below 80 is considered microcytic anemia. And generally speaking, microcytic anemias have a low reticulocyte count. So if you remember from the last show, low retic count means you have a poor red blood cell production, and we get a low retic count because we're putting out really immature red blood cells, not really functioning red blood cells. That's what the reticulocytes are. We're going to start with iron deficiency anemia. Iron deficiency is the most common cause of microcytic anemia. I love the most common causes because they're usually what you get asked about, right? And they're usually what you see in the clinic. So it kind of makes sense. And these go hand in hand. So I love focusing on the most common things. Do other things happen? Absolutely. Should we learn other things? Yes, we should. But it makes the most sense to spend the most time on the things that are... Oh, I just realized I wasn't recording the video, and I usually post that in the app for people who have that. Oh, so we'll start it there. So I like to cover the things that are most common because I think they come up most in the test and you see the most. It just makes sense, right? So in my way of thinking, I spend the most time on the things that are most common, most likely to come up. Causes of iron deficiency. Occult blood loss should jump right up to you, right? If you can't come up with any reason for an iron deficiency in someone, an occult blood loss, so a GI bleed, think about NSAID use. Irregular uterine bleeding is a good one. So if a patient has heavy menstruation or prolonged menstruation over years where there's a problem, then they can wind up with iron deficiency anemia. So definitely have an eye out for those kind of things. Decreased iron intake can cause an iron deficiency. That makes sense, right? Children, pregnant women, or just straight up malnutrition. And decreased iron absorption. So from something like gastric surgery where you're not absorbing the iron as well. Clinical presentation. So we talked a little bit about the clinical presentation for anemias in general. And you're going to get things like fatigue, irritability, that type of thing. But with iron deficiency anemias, you're going to get mouth ulcers. You can get palpitations. Brittle nails is one that steps up here. Pallor is obviously a pretty general anemia issue. Smooth tongue is one I would mark as specific to iron deficiency. Angular cheilitis, so inflammation at the corners of the mouth. Dysphagia. And then the one that's most pathognomonic for iron deficiency is pica, which is eating non-food items, including dirt, paper, hair, and ice. Interestingly, my brother was just diagnosed with iron deficiency anemia, and he couldn't figure out why he was so tired all the time. I mean, it's hard when you go into the doctor, right? And they're like, "Oh, are you feeling tired?" And I don't know if you have kids, but the answer is yes. I have since, for the last 12 years. I've been tired. And then especially, or are you anxious? And in the last 2 years, you've had COVID and everything else going on and people losing their jobs and this and that. So it's hard to parse some of this stuff out. So when he was, asked if he was tired, then they were in his blood work and they found he had this anemia. And then he put the pieces together and realized he'd really just been eating tons and tons of ice, which was funny to him in retrospect, but something he didn't even notice he was doing. So definitely pica is something that's pathognomonic. So eating non-food items for an iron deficiency. These other clinical presentations might be helpful in painting the picture, but things like brittle nails, that's helpful. Smooth tongue and pica are really the ones that should jump out. This is often also, just like it kind of was for my brother, an incidental finding on a routine lab work. Labs and studies, obviously a CBC. Again, I'm not going to repeat that throughout for every single anemia, that you're going to have the hemoglobin hematocrit decreased. If I miss that as we go, please understand that that's going to be for every single one of these. These are going to be microcytic, of course, with a decreased retic count. Iron deficiency anemia will have an increased red blood cell distribution with RDW, which means our red blood cells will be varying in size. On our peripheral blood smear, these will be hypochromic, and you'll see target cells. So one way we identify anemias, right? One is with the lab work, not the lab work. One is with the CBCs and the numbers. The other was with a peripheral blood smear. So looking at what the cells actually look like. So a bunch of them look really pale. We have hypochromic red blood cells. And then target cells, like I said, those have that pale central part and then red around the outside. So you see that on a peripheral smear, that like you would see something like a sickle cell anemia. You'd look at the cells and see that they have that distinct shape to them. You'd also wind up getting iron studies on these people. Ferritin, that you want to get a ferritin level. That's the protein used to store iron. A plasma ferritin less than 10 in women and less than 30 in men is diagnostic. Transferrin is a transport protein for iron, that's what's going to be moving the iron around the blood to the places it needs to go. Total iron binding capacity, TIBC, you'll see that abbreviated a lot. This is going to be elevated in someone with an iron deficiency. Because what happens is, if they don't have enough iron, they're going to be pumping out. The body's going to be creating ferritin and transferrin to help transport this stuff around and move around, but there isn't any iron to be found. So even let's say you have 50% of your transferrin is bound up with iron, and then you pump out a bunch more transferrin, but you don't get any more iron, the percentages are going to shift, right? So your total iron binding capacity is going to go up, which is going to be a key to indicating that you've got an iron deficiency anemia on your hands. And then serum iron is going to be low, less than 30. Treatment, ferrous sulfate 325 TID for 6 months. You'll see an increase in hemoglobin before 6 months, but you want to build up those ferritin stores of iron and get that really on its way. Now, people will have trouble tolerating an iron pill, and it causes GI issues, especially constipation. And again, when we talk about treatments, patients with iron deficient anemia should really be worked up for occult bleeding. That's very important. All right, thalassemia is our next. Important genetic information for thalassemia is alpha thalassemia is usually a person of Southeast Asia, China, Middle East, or African descent. A beta thalassemia is usually Mediterranean descent. So these are genetic issues. And if you recall from the last section, we talked about that hemoglobin is made up of 4 distinct proteins, right? Those are your beta chains and your alpha, 2 alpha chains, 2 beta chains. And what we're talking about, the thalassemia, is a problem in either the alpha or the beta I can't think of the word off the top of my head right now, beta parts of hemoglobin. And if you get one of these screwed up, then the hemoglobin molecule is going to be screwed up and it's not going to carry as much oxygen, and you're going to have an anemia on your hands. So for both alpha and beta thalassemia, there are 2 types. You can have a minor thalassemia, which means the gene that doesn't work so well was only inherited from one parent. This is the minor thalassemia. And if you have an alpha or a beta thalassemia minor, generally these people have few or no symptoms. They have few or no symptoms. Their hemoglobin works pretty well. It's not perfect, but it works well enough that most people won't notice it's a problem. They'll have some fatigue, but outside of that, they have very few symptoms in general. Again, could you have someone who does? Of course. There was actually a girl in my PA class, a good friend of mine, who she knew she had a thalassemia. She had a beta thalassemia, I believe, and she knew about it. And we went to go give blood one day, and she was denied because her hemoglobin was too low, so they wouldn't do it. They wouldn't let her do it. And that was kind of what I saw from her as far as how this affected her life. It wasn't really a big issue. It was more of maybe a genetic counseling issue as far as having children go. But for her in particular, it was something she was aware of, but not something that really caused a problem. Now, the big problem comes in with the thalassemias when you have a major issue, which is the gene is inherited from both parents. So alpha thalassemia major is called Bart's hemoglobin. And generally speaking, this winds up in hydrops fetalis, which is a fetal issue where fluid management is a problem because of the anemia. Secondary to the anemia, the heart has to overwork to push blood around, and you wind up with edema in a couple different locations throughout the body, and about 50% of these kids do not survive. So this is a very serious situation. Beta thalassemia major is also called Cooley's anemia, and generally these patients are born without a problem, but then they develop severe anemia after the first year. I think it's even a little less than that. I think it's like 6 months to a year, when the fetal hemoglobin starts to disappear and wane. Once that happens, these people tend to start having a lot of problems. They have a lot of developmental problems, bone issues. Usually their face has a specific structure to it. They can get jaundice, osteopenia, constant fatigue, and these patients typically do not survive past 30 years old. So I just kind of went through some of the symptoms there. Those are for the major one, obviously. The minor, not so much of a problem. Definitive diagnosis for this is going to be electrophoresis. That's how we're going to see exactly what's going on with the hemoglobin molecules. Serum ferritin is going to be elevated. Hemoglobin is going to be very low. And again, we're talking about major thalassemias here, not minors. 3 to 6, normal or elevated retic count. Microcytic, like we said, that's why we're in this category. And on our peripheral blood smear, so when we're actually looking at the cells, understand that, again, big picture stuff. You're actually looking at the cells here. You're going to see you might see target cells. You may see basophilic stippling. Don't get too hung up, again, on target cells or basophilic stippling because they can be seen in lots of different things. Basophilic stippling can also be associated with lead poisoning and sideroblastic anemia, but also with beta thalassemia. Heinz bodies may also be seen with an alpha thalassemia, but again, Heinz bodies, we'll get to this in a little bit at the end, can be seen in a couple places. Treatment, folic acid is going to help. Serial blood transfusion. What's the problem with serial blood transfusions and with any patient that we're giving blood to all the time? Anybody know? Iron overload can be an issue. Genetic counseling, like I said, if you have somebody who has a thalassemia, they're going to require genetic counseling for when they have children. Definitely going to be a concern for their kids. And a splenectomy may be necessary. All right, so we've got sideroblastic anemia and anemia of chronic disease left. Sideroblastic anemia is most frequently an acquired condition, but can be congenital. It's a little bit weird. The books, the review guides that I flipped through, not a lot of information here. Either not a lot or way too much. Again, I try to narrow this stuff down as it comes for your exam, mostly based on that and how you're going to ask questions out of it. And a lot of the stuff I went through is going to be really tough to come up with good questions on sideroblastic anemia. Ones are going to be, that I think are going to be worth you spending a lot of time on to figure out the nuances between them. Ways of acquiring a sideroblastic anemia. Lead poisoning is the big one. That seemed to jump off the page a lot, was lead poisoning. And then you can get alcoholism and then a myelodysplasia. Labs, you're going to want a lead level, a CBC, with all the attributes of an anemia you'll find there. On the peripheral blood smear, basophilic stippling, if due to lead poisoning. So that was kind of your big indicator for if you saw basophilic stippling, it should link in your brain to lead poisoning and sideroblastic anemia, but it certainly can be due to other issues. The more definitive diagnostic test is a Prussian blue staining of the bone marrow, which will show ringed sideroblasts. Ringed sideroblast treatment is going to be treat the underlying cause, chelation therapy for lead poisoning, and then transfuse as necessary. So you can see, as I go through that, I don't see a ton of places to write questions on that a little bit. Again, if you kind of focus on the lead poisoning avenue, there's a couple things you can come up with, but a little bit difficult there as far as how to write a test question, so exactly what to study. Anemia of chronic disease. All right, so what happens here is you have an ongoing issue, some sort of problem within the body that causes a constant inflammation over time. Now, again, don't get so hung up on this because can it happen immediately after a trauma or surgery? Yes, it's possible. But in general, your test and your patients aren't going to be in that edge case. They're not going to be in the what's possible case. So don't get too hung up at way out there. Go with what happens most of the time. The test questions, the test writers are going to not really trying to fool you. They want you to use the information you learned. They don't want to trick you. So in this case, we're going to say that it's anemia of chronic disease is going to be ongoing inflammation for long periods of time, lead to this issue with creating an anemia. And the things that lead to it's kind of multifactorial. You get issues with absorbing and releasing iron, poor production of red blood cells, and a shorter red blood cell lifespan. The three of those combined lead us to an anemia. Some examples of possible chronic diseases: rheumatoid arthritis or systemic lupus, cancer, some kind of lasting infection. I know when I was in orthopedic of foot and ankle, we would have people, diabetic patients with osteomyelitis of the calcaneus or for years, literally years, and we'd wind up amputating them at some point, but these would be lasting infections. So it's a little hard to wrap your head around if you haven't seen that or don't know what we're talking about. People can have infections that go on for years, and we can't clear them. We can't get rid of them. Antibiotics aren't enough to get into the bones of some of these people. You can keep them at bay, but they still have these infections that go on and on and on. And again, eventually you would wind up doing below-knee amputations on these people too, just because you couldn't clear the infection any other way. So that would be an example of a disease that may cause this problem. Kidney disease is another good one. Labs and studies here. Initially, these will be normocytic and then progress to microcytic. So if you want to really dig deep and think about this as normocytic progressing to microcytic, that's okay. But I would tend to think in my head, this is me, what I would do, and that's kind of how I have to express it to you, right? Is how I would study this and how I would try to retain it, is that it is a microcytic anemia, and that's why it's in this section. Is that 100% true? No, absolutely not. If you are a hematologist, is that going to be true? No. If you're a PA student trying to pass the PANCE and you classify it as microcytic in your head to help you remember it, I think 99% of the time you're going to be right. So to me, some of you may be significantly smarter than me, can hold all that in your head. That's fantastic. But if you are, like I said, for what I would do, I would take that as microcytic only and drop that normocytic part just because it's more than I can hold on to. Here we generally have a hemoglobin of less than 8. Treatment is going to be treat the underlying disease. Aren't these your favorite answers, right? Is treat the underlying disease. If you have cancer, rheumatoid arthritis, lasting infection, or kidney disease, or something else that's a chronic inflammatory process in the body, if you can get that under control, it will help with your anemia of chronic disease. Blood transfusions may be necessary as well. And just like that, or at the end of microcytic anemia. Great. That's fantastic. That's a lot of material and a lot of important points. I'm going to come back around and touch on some of these and answer our primary questions in just a second. But first, I want to hit our study tip. And I touched on it in the beginning a little bit, which is to grasp the bigger picture and to make sure you understand what we're shooting for. The key for me in this section is to understand when we're splicing out these different types of anemia, how they're going to be asked from you. They're going to be asked because you're going to have to compare them to each other, right? You're not going to get a test question that's going to compare someone who might have lead poisoning and to someone who might have heart failure or someone who might have a broken bone. It's not how your test questions work, right? You're going to get a test question with a vignette, and then in that vignette, it's going to have something like sideroblastic anemia, iron deficiency anemia, and you're going to have to differentiate between those to answer the test question. That's how the test works. If you haven't figured that part out yet, you really should start to notice it. That's how the answers work. That's how the questions work. So what you really need to focus on in this kind of a section is to see the bigger picture, understand how you're going to use the information given to separate these things from each other. I'm going to cover just a little bit of that in a second, but I want you to understand, like I said, the bigger picture. One, in a test, but also in the clinic. When you get a hemoglobin back of 8, the question is going to be, why is the patient 8? Right? What's going on? Why is it not 15? Why are we down to 8? And if it's a surgical patient who just came out of the OR, you can guess it's probably because of a hemorrhage, right? It doesn't take a big jump. Is that definitely the answer? No, but understand the big picture. What's going on? Is this an older patient? Is this a younger patient? Is this an infant? Is this just a newborn? What kind of patient are we looking at? What's going on in the bigger picture? One of the examples I loved, I just took an ACLS course, and it was an emergency doc who does the course. And he would ask as we went through the different rhythms and we went through the different scenarios, he would ask very bluntly, is your patient stable, unstable, or dead? And it would kind of hit you between the eyes, and you'd be like, oh, wait. You'd get so caught up in the questions, you forget to see the bigger picture. And you'd be like, oh, he's dead, so we have to shock him. And he's like, yes, of course. That's the only thing we can do. And by dead, he meant VFib. And the only thing you're going to do is shock them, right? If they're stable, then we have a couple minutes. If they're unstable, then we need to move. And it was kind of a way to bring you back to away from the mannequins, away from staring at the monitor, because that obviously drives you crazy, and you just sit and stare at the monitor as it blips past. And he's like, actually do something. Think about the whole picture. Understand what's going on. Is your patient stable, unstable, or dead? Then act. And once you have that in your head, you can start to move. You can start to feel it. It's working through things on a test question or on a mannequin is much different than working through them in the clinic, because you don't have that whole picture. And you need to start bringing that into your studies and into your tests. If you can see the thing in your head and picture yourself in the clinic or picture yourself in the emergency room, it'll make it much easier to get it. Or if you can picture how you're going to answer it on a test question or how they're going to present it, and see how these things apply and interconnect, because that's really the key to all of this. If you memorize each of these as independent data points, very, very difficult. If you memorize them as part of a whole big picture, much, much easier. And like I said, in the May issue of the Physician Assistant Exam Scholars newsletter, which goes out May 1st, I go into this in a lot of detail and talk a lot about how a specific method I have for categorizing material. Actually, it was part of the BLS course, is where I was taking when I realized how much I use this technique in categorizing information to make it easier to hold on to for when you see it on a test, and easier to remember when you're holding on to a test. And a lot of it has to do with seeing the bigger picture, but a lot of it is also very specific ways of categorizing things within that bigger picture. So if you're interested in a little bit more detail, that might be where you could go ahead and get that. And all right, so from here, let's go on to what I wanted to wrap up a little bit differently. We'll get to the answer to the priming questions in just a second, but I think this is actually more important, is how do you differentiate microcytic anemias from each other? And what are some terms that are helpful or not so helpful? So and again, I hesitate to say this because this is how I would do it, but I don't want you to get too hung up and get something wrong and then come back and be mad at me for it, because these are probably 80-90% accurate, and there will be some outliers where it is wrong. But to me, I always play the odds with this kind of stuff. And because again, I don't have the memory capacity to hold on to every single detail. So if I can get something and I can memorize it and it's right 90% of the time, and that's probably what they're going to ask a question on in the test, then that's even better. So I'll take that risk. So that's what I'm presenting here. These aren't 100% accurate. They are 95% accurate, but it's the easiest model. Rather than trying to memorize 100 things, I'm going to give you 4 or 5. And then once you get better and you want to expand on those, great. But start here if you're beginning. So how to differentiate microcytic anemias, because that's what you're going to have to do on your test, right? How do you separate 2 different types of microcytic anemias? Hopefully they don't even make it that hard. Hopefully they make you separate out a microcytic versus a macrocytic, and then it'll be easy once we go through in the next show. But anyway, if you see the term hypochromic, it's generally going to be an iron deficiency anemia. Not always, but generally speaking. If you see target cell and microcytic, then you're looking at a thalassemia. Target cells will come up in other places, but not in a microcytic anemia, and again, generally speaking. Same thing with Heinz bodies. Heinz bodies, if it says microcytic and there are Heinz bodies in the peripheral smear, then you know that you're talking about a thalassemia, or at least you can presumably assume you're working with a thalassemia. If your total iron binding capacity is increased, we're probably looking at an iron deficiency. If your total iron binding capacity is decreased, we're probably looking at anemia of chronic disease. Most likely. And the reason I separate these out, and that's the only few that I'm going to separate out here, is because you can memorize whole lists of data, or you can memorize the 1 or 2 things that differentiate. And those 1 or 2 things that differentiate are what you're going to see on a test. And they're also going to be what you're testing for in the lab and in the clinic, because you need to get down to an answer somehow. So if all you have is microcytic and some descriptors, you're not going to get there. They have to give you these more specific pieces to the puzzle, but you have to know them. And this is how I separate these things in my head and how I know to look for on a test. There are a couple other terms that are what I would say are marginally helpful. So things like Heinz bodies, I mentioned. If microcytic, then you're looking at thalassemia. But the reason I say marginally helpful is because they can also be part of a found in hemolytic anemia, and a G6PD deficiency, which we haven't talked about yet. We'll get to. But those are other types of anemias, so I think that's easy to confuse. So if you rely on Heinz bodies to figure out that you have a thalassemia, I think you're going to be in trouble. I'd rather use those two. The way that I refer to it is I use the main information to find out that I've got a thalassemia that I'm working with, but then I use the Heinz body as almost a supplement, to kind of shore up my self-confidence about that answer. So I wouldn't look for that off the bat, but then if I saw it and I was like, oh man, I think that had something to do with the thalassemia, that makes me feel a little better. That's kind of how I would treat Heinz bodies. Again, you may vary and your brain may be is most likely different from mine. So the way you approach this may be dramatically different. Another one is basophilic stippling. Kind of helpful, but not really helpful because it can be found in sideroblastic anemia, most specifically lead poisoning, and that seems to be the big place. So I've kind of bolded it in the notes because that seems to be kind of the flashing red lights. If you see basophilic stippling, you should think toward lead poisoning, but it can also be seen in thalassemias, sickle cell anemia, and a B12 or folate deficiency. All right, I hope that's helpful. I hope you start to understand and start to see the way that I think about this stuff, the way that you should be thinking about this stuff, that there's a specific way of approaching all of this. It's not just memorizing data points. You're trying to figure out how to pass tests. You're trying to figure out how to hold on to information for the clinic. You're trying to figure out how to help your patients and help yourself. And if you just hold on to individual data points, tests are very, very hard, right? And I think when you do it with a little bit of style and a little idea of how they interconnect, things start to open up and become much, much easier. All right, so let's move on and answer our priming questions. What is the test for measuring red blood cell size? Red blood cell size, that was mean corpuscular volume. Define microcytic anemia, less than 80. Give 2 symptoms of anemia. Maybe we can go through a bunch here. I have fatigue, pallor, brittle nails, dizziness, tachycardia. But I think you could make that list 20 things if you wanted. Give 2 causes of anemia. Hemolysis, low iron, low folate or B12, hemorrhage, chronic disease, thalassemia, lead poisoning. Again, that list can go on for quite a while. And we haven't even gotten to most of these yet. What type of anemias are associated with Heinz bodies? We just went through this. See if you have it. What's the big one? Oops. No, not necessarily the big one. What was the one that was important that we covered today? Heinz bodies. So thalassemias were the ones we covered today, but you can also have hemolytic anemia and G6PD deficiency. All right, well, that wraps up our priming questions for today. And while I'm on the topic of priming questions, I do want to point out if you get a lot out of these questions, the final step is the book I wrote that contained questions just like these. The first edition is just about to be retired. The second edition is due to be out in early June. That's my plan. I have it out to it's being worked up right now. I've got a new cover that's being worked out, and I'm really, really excited about that. It's actually going to have almost double the number of questions in the original version. So if that's something that you like, these priming questions, and you like how they help to set you up and to review the material, that's a place where you can find tons of those. So that's in the final step. I'll get that more information out to you as we move a little bit closer, but just so you know that that's coming in June. The first edition is just about ready to be retired, which is really exciting. That's helped out. I think it's almost 10,000 people now that book has helped to pass their exams, and I can't wait to get the new edition out. I've been meaning to work on this for a long time, and finally this year it's something that got pushed up to the top of the list. I'm really, really excited about that. Anyway, if you want to know more about that as it comes, or if you want to find out more about the Physician Assistant Exam Scholars Program and the newsletter I was talking about earlier, go over to the website, www.physicianassistantexamreview.com, and you will find yourself a way to sign up for the email list. And then once you sign up there, you will get tips, tricks, information on how to pass, how to do well in school, all kinds of stuff there. And in addition to that, you will find out all the information that you want about how to sign up for the Physician Assistant Exam Scholars Program and newsletter, and to get your hands on a copy of that new edition of The Final Step when it's ready. I think that's it. That'll about take us out for today. Thank you so much for joining me. I'm excited to be back behind the microphone in 2021 here. And this has just been a ton of fun. I'm really happy to be back doing this. And I wouldn't be doing it if I hadn't heard from so many of you about how helpful it is and when I was going to restart the show. So thank you so much for that. I really appreciate it. And take care. I'll see you in a couple weeks.